And Gail, thank you for the wonderful collaboration. I know Jean Bennett sends her regards. And here we go. Okay. Our learning objectives that we have for today have been are seen here on the slide. So we have key SAMHSA recommendations for providing evidence-based treatment, particularly for patients who have opioid use disorder during pregnancy and the postpartum period. We're going to be looking at some of the benefits as well as the drawbacks of using medication, and also really identifying why we want to avoid detoxification or withdrawal during pregnancy. And then finally, articulating actions that you can take today to help support, uplift, and affirm all patients who have substance use disorders while they are pregnant and postpartum. I don't have any disclosures relevant to this presentation. And what I also really love to do, since I do not have a person with living experience with me today to present, I want to take a moment to share a very brief video about her experience and what helped her feel safe. And so I'm going to stop sharing and reshare a video, and we will listen to what Chelsea Moore, a proud woman in recovery, has to say. Chelsea, thank you so much for being with us today. And what would you like to share to help providers best understand how to provide compassionate, responsive care to pregnant and parenting women with children who have substance use problems?
So I'm Chelsea. I am a person in long-term recovery. For me, that means I have not used drugs or alcohol since November 24th of 2022. What kind of pushed me into seeking help was finding out I was pregnant and not being able to stop using. And there was that innate fear of getting help when you're pregnant because your first thought is losing your child. And you want to try to do what's best for yourself and your child, which is getting help. So that was one of my biggest fears and biggest barriers, I think. And when I found Horizons, I remember going to their outpatient clinic for like my first kind of prenatal checkup with their provider there. And from the moment that I walked in the door, they just made me feel so welcome and unjudged. And that started at the reception from like that first person that I saw there. And she just made me feel just very welcome, very sweet. And then the nurse that checked me in, like, I just remember how kind she was. And she even told me a little bit about herself and her story and her experiences. And that just really put me at ease. And then I think I felt like there was just kind of a wraparound care that was provided at the program that I was at, which was, I feel like, what made the biggest difference in me staying and leaving and, you know, getting into recovery. And I think if I had faced people who were more judgmental of the things that I had done while pregnant, you know, like when telling my story in the beginning, it was I overdosed twice while pregnant, and I was using up until I was 5 months. So I was visibly pregnant, like very pregnant. And there was instances where I was seeking help in other ways at other doctors and, you know, the emergency room, and just the looks and the vibes you would kind of get from different doctors is so like it makes a difference in how I felt about myself as a person and as a pregnant person trying to get help. And at first that even pushed me further away from wanting to seek further help because I felt so judged when telling doctors, you know, yeah, I've overdosed pregnant, you know, twice and all these things that I had done. So I think just having that compassion and that empathy and that understanding when you're providing care to women and women with children, women who are pregnant, trying to find recovery and trying to get the help that they need, it can make a lasting impression.
Thank you, Chelsea. And we will be all right. So you got to hear from a wonderful, proud woman who is in recovery and what those important things were to her, right? The idea of not feeling shame, not being judged, being open and welcoming in our approach to our patients, and all patients deserve that. I want to kind of then focus now. We're going to come back to Chelsea's thread. I will weave that in throughout this presentation. And I want to remind us that over 48 million Americans have a substance use disorder. And we have to recognize, I'm sure you heard yesterday, right, of the poisoning of our drug supply, right? And this is a quote from Oregon. Who said that I think a person from Oregon who said, I think everybody I know who's a drug user has overdosed at least once this year, right? And that is only the tip of the iceberg. Where we see overdoses, we know that there are at least 30 other individuals who are going into the hospital to seek care and not dying, thankfully. But this is just the tip of the iceberg. And so we know we also have suicides, and underneath that, the underpinning, which we hear so often and see in our daily practice, is the need for behavioral health resources, the need for additional housing, the pain of the grief and the loss that all of us have felt when we are losing loved ones to drug addiction. And of course, there is the financial burden but the psychological toll that it has taken on this country is absolutely not able to be fully calculated in financial terms. And when we also then focus on people who are using substances during pregnancy, we have these data from SAMHSA, which just are a reminder that we can't forget about our fully legal substances. Our tobacco and our alcohol, as you can see in this slide, are the ones that are most commonly self-reported by pregnant individuals. And when we look at our illicit drugs, we see that a much smaller proportion of participants are reporting some type of illicit substance use, recognizing that cannabis is has a variable legality in different places in our country, and knowing that cannabis is the most common self-reported substance that is considered illicit federally. And so that means that we have to make sure that we're asking about all of those different substances during pregnancy so that we can be able to have the most compassionate response. I want to ground us as we talk about substance use disorders into what is a substance use disorder. And so we know that there are really only two physiological signs of a substance use disorder that's been defined by the DSM-5. And so we know that those physiological aspects are the tolerance. So if you take a drug one time, you take that same amount the second time, you end up getting you don't get the same effect, so you have to take more drugs. So that's the buildup of tolerance. Withdrawal is sort of the opposite effect of the drug that you've been taking. So, for example, if you're taking opioids and you are feeling everything slowing down, you've got a little drier mouth, drier eyes, your gut is kind of slowing down. When we abruptly stop taking those opioids, we get the opposite. So we've got runny eyes, diarrhea, vomiting, nausea, and we feel horrible, like the worst type of flu. But those are, again, are only two physiological signs that we have. Everything else is behavioral when we think about impaired control, right? We wake up in the morning and we tell ourselves, I'm only going to take one hit, and we end up taking six. That's an example of impaired control when we have that unrelenting craving, when we tell ourselves 100 times over the days, I'm not going to use. And then, we've kind of wear down and we end up using and using more than we expect. And then there's the issue of impaired social control, functioning in impaired relationships, right? So we're just not able to be the people we need to be to pick up our children from school, to be able to hold and maintain a job, to be able to complete educational assignments. And we have disrupted relationships, conflicted relationships. And then finally, that last kind of sign of substance use disorder is continuing to use in spite of those negative health consequences. So, for example, having hepatitis C and continuing to inject a substance, or maybe driving a vehicle impaired. So the DSM-5 has also given us a continuum of mild to moderate to severe. So we know those individuals that come to see us and need our help have at least six of these signs. What I also want to remind us is that those signs can also be the same things that make us feel really frustrated as providers. Why can't we just get somebody to stop, right? And that's because it is that brain illness that has convinced their brain that they need this substance for survival. The other thing I would say is that substance use disorders are actually pediatric illnesses, right? It is a developmental disorder. When we ask adults that come into treatment, when did you start using substances? Over 40% are going to tell us that they started using a substance under 14 years of age. And for many of the patients that come to UNC Horizons, they've started using somewhere between 5 and 10 years of age. And so we need to have a better response in the District of Columbia as well as other places so that we're assessing, evaluating, identifying, assessing as early as possible those opportunities to be able to intervene in that substance use. So, other important pieces about talking about substance use disorders is dopamine, right? So, dopamine, I want you to remember, is motivation. And we know that we need dopamine to survive. Yes, we need food. Yes, we need oxygen. Yes, we need water, and we need dopamine. And so, if you're having an average day, maybe listening to a webinar like this, you probably got about 50 nanograms per deciliter of dopamine floating in your brain. If you were having a fantastic day, you won the lottery, you're looking exactly the way you want to look, you're having great relationships with everybody, maybe you have 60 nanograms per deciliter of dopamine in your brain. But when you take drugs, that overwhelms our system with our brain with the dopamine, right? It can be up over 1,000 nanograms per deciliter of dopamine floating in our brains. But what happens is that is not sustainable, right? Our brain comes up with ways of not making of making less dopamine or not being able to use the dopamine that's floating in our brain. And so for the patients that come to Horizons, the pregnant and parenting individuals, they can have on average about only 10 nanograms per deciliter of dopamine in their brain. And what does that mean when we have low dopamine? It means that we have craving. It means that our patients are tricked into survival. So that low dopamine means they need that drug to survive and that they end up creating and breaking every value that they have, everything that they hold dear to them, just to be able to feel normal, not even to be able to feel good. And so this is actually an interactive question for you. And I hope that there is a chat function that you will be able I'd love to be able to use the chat function to see what barriers do you all see pregnant women and people facing in seeking treatment for substance use disorders in the district. And I'm going to give it a minute for you to think about that and would love to have some interaction in our chat.
Everyone, I believe you should be able to join the chat and just make sure you're responding.
Okay.
So,
So are we not able to have people join the chat or are they just not joining?
let's try to figure that out. Chat
Okay.
is disabled, the Q&A is active.
All right. Well, I'm cognizant of I want to be sensitive to our time, so I'm going to keep going. And if we can figure it out, I would love to hear your thoughts about what barriers you all are seeing pregnant individuals face. The biggest barriers that I see and that are consistent in the literature, bar none, is fear, right? We have seen this early on in the literature, as you can see in this slide, and examples of fear from 1971 all the way to 2024. Our patients are fears. They fear loss of custody. They fear stigma and invasion and loss of privacy. They fear not wanting to be away from their children or their partners. And then there are other barriers to treatment too that include both a lack of childcare and a lack of transportation. We know that we have fantastic data to show that when we can provide treatment to patients that have substance use disorders, that we are able to modify their birth outcomes. We're able to improve their birth outcomes so that they look more like individuals that don't have substance use disorder treatment, or that don't have substance use disorders at all. So you can see that reflected in our preterm birth, our low birth weight, yeah, so I think that this gives us confidence that we know that substance use treatment, even if people are not able to have cessation of substance use, that if we can at least get people prenatal care and get them substance use disorder treatment, that we can optimize maternal health. So what is both SAMHSA as well as ACOG and other places invite us to do? Universal verbal screening. And it starts at the first prenatal visit, right? That doesn't mean it's the only time that we're doing this, but we're repeatedly doing this. And I know that there's a great concern around confidentiality and privacy of our patients. So I want you to think about that shared decision making. We need to tell patients what we're going to do with this information. You need to ask your hospitals, look at our policies. What is the guidance that hospital policies are giving us in order to protect our patients' information and also to be able to respond in a most and highly supportive way? And these screening tools are really intended to be the start of a good conversation, to establish good clinical rapport, follow up with brief interventions. And our hospitals need to know there needs to be a whole process, a workflow that's there so that our providers feel supported, that when patients do say, yes, I am using substances, that they know what the resources are to be able to refer them to. This is another example of where I'm going to infuse things that Chelsea, as well as other patients at Horizons, have told us about what their recommendations are for screening. So one of the examples, I won't read them all, but just a few here, you can read them on the slide, is tell us up front what's going to happen to this information that we share. For example, is everybody in Epic going to see it? Tell us before you ask us the questions so that we then know we're empowered with information to decide how we want to respond. Explicitly state that we ask all of these patients these questions and not just ask those patients who look like they're using drugs. And finally, tell us about the importance of catching health issues as early as possible in pregnancy so that we have time to make changes. Right? So we need to be able to screen. Um, and I, again, it's that idea of universal verbal screening and not relying on urine drug testing or other toxicology testing. We know that those tests are short-term tests. If you're using screening tools, we know that they are highly imperfect, that they would need to be confirmed with other GCMS or other types of validated tools. But I'd also invite us to ask, why are we taking this test? What are we doing with the information? And how is it going to change our clinical response to our patient? So verbal screening, validate that answer with the patient. So if the patient says, yes, I'm using, let's normalize that. Let's affirm, recognize that this is an issue and ask how that patient would like to be supported in going forward and making behavioral changes or not, and to what extent. So we want to support, we want to assess to see to what extent it is substance use or substance use disorder. And then where it is a substance use disorder, we want to refer and treat. And I put some sample resources here. There's some fantastic resources on the website that you can see. When we talk about medications to treat opioid use disorder, we have three that we can use during pregnancy. These are discussed in the SAMHSA guidance documents and ACM guidance and other places. And what we know about these medications, just to kind of level set, given a mixed audience, we know that methadone is a full mu opioid agonist. What that means is that you have all these opioid receptors in your brain. The methadone comes in, locks onto the opioid receptor, and turns it on fully, like a full rheostat light switch, right? So the more medication you give, the more effect you get. With buprenorphine, it's a partial mu opioid agonist. What does that mean? It means you have these opioid receptors in your brain. The medication comes in, locks on the receptor, turns it on about halfway, which means that the more medication you give, you don't necessarily get more physiological effects. So we don't get as much suppression in breathing or suppression in heart rate. It's like there's a ceiling, there's a limit to it, and it can still be really effective in treating opioid use disorder and covering all of those opioid receptors. And then finally, there's naltrexone, which is a full mu opioid antagonist, right? Which means you've got your opioid receptors, it comes in, locks on, but then doesn't light up the receptor at all. And patients don't, by and large, really like taking this because if you get an effect, it's kind of maybe a mild nausea, maybe some headache, maybe some mild withdrawal feelings. And so that's why it's often given in the most effective form is in an injectable form. So you can take it once a month and you don't have to think about it anymore. So when we have patients that are in untreated opioid use disorder, their days can often feel like, in severe withdrawal to up to euphoria and back down. And they're trying to find what is normal, right? And medication can create that feeling of normalcy so that people then are stabilized and then they can take the next steps in other aspects of their life that they want to continue to pursue and thrive. So I don't know if the chat is working again, but here is another question as to if you would like to answer it. I invite you to do so. what are some reasons why medications to treat opioid use disorder are important for healthy pregnancies and healthy deliveries?
Yes, so our chat is disabled. However, you guys
Okay.
can use the question A function, and Henry Jones will be able to view that and maybe share a little bit of what you guys are sharing.
Thank you so much. And I don't see the Q&A chat here, so maybe we wait till the end and we can have that conversation. Is that okay?
Yeah, definitely, whatever works for you.
Okay, thank you. So I want to just kind of share a little bit about the history of methadone. Why do we use methadone during pregnancy? How did we get to buprenorphine? And so one of the really important things about methadone, it was the only medication that we had to treat opioid use disorder for decades. And you can see here the kind of the arc of the publications that have been done. And one of the, I'd love to call out Dr. Melissa Freeman because she is the first Black physician that I know of that treated pregnant individuals for opioid use disorder. And she did this in the Bronx. And in fact, her data were actually published by Dr. Newman, and she was not a co author on that publication. And we have 120 deliveries from her patients in New York City that really set the platform for the very first data, large data set of relative safety and efficacy of methadone during pregnancy. The issue that was of concern for many patients as well as providers is that development of a baby withdrawal, that neonatal abstinence syndrome or neonatal opioid withdrawal. And so this is just a slide that really kind of breaks it down into what it is, right? So we have increases, when we have that withdrawal, we can have increases in acetylcholine, which can be expressed in diarrhea and vomiting and sneezing. We're going to have decreases, sorry, in dopamine, which can create that hyper irritability or anxiety. We can have increases in corticotropin, which can increase stress, increases in noradrenaline, which can give us our tremors. We can have decreases in serotonin, which can create that disruption in sleep. And so, while we know that we can break this down into a pathophysiology, we also know that we have responses for it. So, we have very important tools to be able to identify it. We have assessment and then medications to treat it when needed. And we'll talk a little bit more about that in a few minutes. So, we only had methadone. Methadone was shown to develop, babies developed a withdrawal after they were abruptly discontinued from that medication in utero. And so, come fast forward to the late 90s when buprenorphine came into the investigational new drugs supply. And we realized was that for adults who were abruptly discontinued from their buprenorphine, that they had a much milder course of withdrawal compared to withdrawing from methadone. And so the idea was, well, if that's true for adults, perhaps that would be true for babies too when they were abruptly discontinued from buprenorphine when the umbilical cord was cut. And so we have a whole bunch of publications looking at open label studies. And what we found was that when patients and doctors knew which medication that the birthing person was receiving, that there was very little neonatal abstinence syndrome. But if you talked to the nurses who were doing the neonatal abstinence scoring, what they would say is, oh, I knew that patient was on buprenorphine. So, maybe the baby was just a little colicky. Yeah, maybe there was a tremor or two, but that wasn't really withdrawal because we know that buprenorphine is going to be better, right? There was a bias. And so we needed to do double blind studies in order to alleviate as much of the bias as we could. The other important part about the studies that we did is that we could not have a placebo or a control comparison condition because we had Johann Keiko and others' data that showed that buprenorphine actually keeps people alive. So there was a randomized study where he put people on placebo versus buprenorphine, and that study was stopped, one because of treatment retention, and two, because four people actually died within this study. And so we had important proof that buprenorphine truly was saving lives. So when we did this double-blind randomized study called the Mother Study, which meant that patients received either methadone or buprenorphine, they didn't know what they were taking, nor did the prescribers giving the medication in a flexible dosing paradigm. That when the nurses who were doing the neonatal abstinence scoring also didn't know what medication the patient had been receiving. And so what we saw was that under double-blinded conditions, the proportion of babies treated for neonatal abstinence syndrome weren't different. But what was different was when babies needed treatment for their neonatal abstinence syndrome, we found that the babies prenatally exposed to buprenorphine required significantly less medication, and subsequently they got out of the hospital at a shorter period of time. The other important thing, so while buprenorphine did seem to be more favorable for neonatal abstinence syndrome, both of these medications, both methadone and buprenorphine, in the context of comprehensive care, provided pretty similar outcomes for the birthing person. And so that what that did is that set the occasion for actual randomized safety and efficacy data for both methadone and buprenorphine. So we could have two forms of medication that could be used for opioid use disorder during pregnancy and the postpartum period. The next question was, well, what about the children? How do they develop? So we looked at 96 of the children, followed them for up to 36 months, and we looked at them compared to each other, methadone versus buprenorphine exposure. We looked at them compared to the norms on the different types of assessments that we gave them, and we really found no patterns of differences in physical development, cognitive development, or behavioral development. So what that told us is this should be relatively reassuring for both the families as well as the providers of the medication to say that pretty much our children are developing within normal limits. Post mother, because it's been over 10 years since those data have been available, what have we seen in terms of prenatal opioid exposure? And there have been a number of meta analyses, systematic reviews. We actually, the Carter 2024 is the most recent one that we just published, looking at prenatal exposure to medication to treat opioid use disorder or prenatal exposure to opioids in general. And if you can see here, what's highlighted is that by and large, we don't see differences, especially when we control for other factors, including tobacco. So that study by Nelson et al., that when there were differences in development, really tobacco was a contributing factor. So if we've learned anything, we really want to be supportive to our birthing individuals to help support them in thinking about reducing or stopping their tobacco use. So the other thing I want to say is that I want to encourage you to really think about the literature when you see sort of the taglines of things like neonatal abstinence syndrome and high school performance. When you dig down and look at that very carefully, these very large data sets, what you're going to see is that having a neonatal abstinence syndrome, being prenatally exposed, really only explains a tiny proportion of the variance of whatever overall outcome that you have. And so that means that there's a whole lot of other things that are really driving that outcome, and not necessarily does the statistical significance of having a neonatal abstinence syndrome really equal clinical significance of having a neonatal abstinence syndrome in the long term. So these are the SAMHSA clinical guides that were guidance recommendations, the top ones that were published in 2018. There's also 4 newer fact sheets that are how to work with child protective services and the patient that is in front of you. And then there's also a newer document I'll talk about in just a sec. There are 16 different fact sheets going from prenatal care all the way through maternal postnatal care. And so we're going to talk about the different types of recommendations. One of them is that we know that medication assisted withdrawal isn't recommended during pregnancy. We know that methadone and buprenorphine are the safest medications. We know that we don't want to transition patients if they're having a good clinical response. So if it's working, please let's not create a vulnerability in our patients that doesn't need to be there. We want to recommend breastfeeding. It is a human right according to the WHO, and neonatal abstinence syndrome shouldn't be treated with dilute tincture of opium. So let's talk about why detoxification is not an effective strategy for managing opioid use disorder. One, we're not able to avoid neonatal abstinence syndrome. So a lot of times we'll hear, oh, if we just if the mother doesn't take anything or the birthing person doesn't take anything, we can avoid neonatal abstinence syndrome. That's actually not what our systematic reviews show us. And it's a mismatch, right? It's an acute care approach to a long-term chronic condition. So it just doesn't match very well. And we also know that in the first month after detoxification, on average, about 80% of patients have a return to substance use disorder, and that includes pregnant as well as non-pregnant individuals. Other advances that are important to point out is that neonatal neonatal opioid withdrawal syndrome has been defined and by the Food and Drug Administration, and we know that that is really a subset that is specific to babies that have only been prenatally exposed to opioids, where we know that for the vast majority of our patients, that's not their clinical or living experience. We know that most of the time we have other polysubstance exposure. And so that's why I continue to use neonatal abstinence syndrome, because it's a much more umbrella term. It's a catch-all term. It's also important to note that if you remember our DSM-5, you have to continue using substances in spite of a host of negative consequences. And babies just don't have that experience, that life experience to continue using substances in spite of negative consequences. So babies cannot be born addicted. They can be born in withdrawal. They can be born physically dependent, but not addicted. We also know that we have great paradigms to treat neonatal abstinence syndrome. And if we can start from the very beginning with positive interactions between caregiver, birthing person, mom, and baby, that creates an opportunity for an upward spiral so that we can help boost resilience factors and minimize long-term effects. The other thing I'll point out on this slide is that we do have a definition of neonatal drug withdrawal that has been proposed, and this was really the first clinical definition that also embedded within it foundational principles for that opioid withdrawal definition. And so just recognizing that having a diagnosis of a neonatal abstinence syndrome or neonatal opioid withdrawal syndrome does not imply harm, nor should it be used to assess child social welfare risk or status. And it should certainly not be used to persecute or punish mothers or as evidence to remove a neonate from prenatal custody. So what else has SAMHSA been up to? There in 2023, there was an update of the guidance that is in a 12-page document. Two highlights I want to mention from that is that they're very supportive based on the literature of increased or split dosing for methadone and for buprenorphine. And so we know that when we are providing the right dose of medication on the right times of the day, that we can get much more optimal responses for the birthing person, for fetus, and then also postpartum is very important for that bonding between birthing person and child. And then also too that we need to have services that are culturally and linguistically effective in order to be able to have the best and most optimal outcomes for our patients. Unfortunately, we also know that medication to treat opioid use disorder is not fully available everywhere across our United States. As you can see on the East Coast, we're doing really well. DC is looking pretty good, but that is not the case for all places in the United States. These are data from DaVita Shift, which just drive home the importance of medication to treat opioid use disorder. So you can see on the top panel, all overdose events are in that blue, and you can see an uptick in the 7 to 12 months. And then when those data were separated out and we could see overdose deaths on pharmacotherapy and overdose deaths without pharmacotherapy, what you could then see is that our overdose deaths with pharmacotherapy were less than those without. So we know that these are life-saving medications. We also know that we have incredible racial discrimination about who has access to the different medications. And you can see that reflected in this slide here. And just to highlight medication access disparities among Black, non-Hispanic, and Hispanic women, we know that they're significantly less likely to use medications compared to white counterparts, and that non-Hispanic, Black, and Hispanic women are less likely to receive medications during pregnancy as well as the postpartum period, and they're also less likely to continue medication. So these are important data that give us an opportunity to really ask questions, to look at how we are providing medications, and to change the paradigms, to question the paradigms, and provide more support. Other things to think about in this age of fentanyl plus all sorts of other toxic adulterants in our poisoned drug supply is that we want to make sure that we are using methadone if that is something that patients want. And we need to know from our patients before we're providing that medication You know, they need to be transparent with us and we'll be transparent with them. We need to ask about oversedation as well as under sedation and looking for signs of withdrawal. We know that we might need to start out higher and ramp up the dose more quickly. We might need to divide the dose in halves or thirds or fourths. And we need to listen to our patients and talk to our patients about how the medication is working for them and be able to respond when they say it is not working. The PCSS provides nice practice-based guidelines for buprenorphine in the age of fentanyl, and so it's a whole new era in terms of low dose or high dose buprenorphine administration. There's protocols for home induction now. So just the idea again of being able to listen to our patient and best respond, and to help them also co-prescribing naloxone and talking to them about how to use it, providing that naloxone to patients' families is also really important. Having a safety plan for where medication is going to be stored, and that's true for methadone as well as buprenorphine. And then for buprenorphine, one of the things I see is so often patients aren't taught about how to self-administer it properly. So, for example, there's a jail that I've interacted with where they only allow the patient to have medication, buprenorphine, under their tongue for 30 seconds. That is not sufficient to be able to have the buprenorphine work as it should. So we need to let it dissolve under the tongue. And if they're swallowing it, the medication is going to be less helpful. Other questions that we get about buprenorphine is, can we use the combination product, that buprenorphine plus naloxone? And the answer is yes. We have systematic reviews. ACAM 2020 guidance also supports that it is a relatively safe and effective medication for pregnancy and the postpartum period. What about naltrexone? There has been a systematic review, and typically what we say is that if patients are already receiving that naltrexone and they're having a good response from it, have informed consent, have a good shared decision-making process, and if the patient, based on the patient's values and needs and preferences and your clinical judgment, if naltrexone is the right thing, let's keep our patients able to receive that medication. What about labor and delivery, right? So often I hear, oh, well, our patients are taking MOUD, so that should be enough to control their pain. No, we know that our patients have more hyperanalgesia. They're more sensitive to that pain. And we also know that patients taking buprenorphine or methadone can also benefit from immediate release opioids postoperatively for acute pain. And we do not want to discontinue their MOUD because that can create a period of vulnerability. There could be a return to use, a decreased stabilization. So we want to avoid partial opioid agonists, also like Nubain, because that can send our patients into withdrawal. So, hospital policies. I invite you to look at your hospital policies with regard to urine drug testing, with regard to Child Protective Services notification, with regard to how NAS is identified, treated, and assessed. Because we know that hospital policies in and of themselves can make neonatal abstinence syndrome look worse or look better. What can make it look better is having a protocol, a systematic protocol that's always followed. If we highly encourage breastfeeding for those who want it, and then keeping birthing person and baby together, we know that data has shown for decades that we can cut the percentage of babies that require medication in half. So birthing person becomes the medication for that baby. We also know that if we can avoid the neonatal intensive care setting just for babies that have neonatal abstinence syndrome, that this too can create a more optimal environment in keeping, again, mom and baby together, birthing person and baby together, can beat that low lights, the soothing sounds. It can just, that skin to skin bonding. The NICU isn't necessarily the best environment for babies that just have neonatal abstinence syndrome. Other things that can also reduce the severity of neonatal abstinence syndrome is the choice of medication, as well as how we are initiating or weaning, or are we using medication as a PRN. So, Eat, Sleep, and Console, if you haven't heard of it, I invite you to take a look at it. It is an amazing program. There's just been a New England Journal of Medicine article that has been published about it, a clinical trial, and they compared Eat, Sleep, and Console to more usual care, which is like the modified Finnegan. And what they found is that using this kind of more collaborative approach of how much is baby eating, how much is baby sleeping, and can you console baby in less than 10 minutes, we can see babies can get out of, they're ready for discharge earlier than their counterparts. And the safety composite score was also very similar. So they're not seeing a rebound effect of adverse events because baby is leaving the hospital early. So the fourth trimester is super important to talk about. And so we know that that is 12 weeks following the birth of the baby. We also know that the World Health Organization recommends seeing birthing postpartum individuals 3 days, 1 to 2 weeks, and 6 weeks after they've had their baby. That more constant communication and attention can be so much more helpful for protecting the birthing person's health as well as the health of the child. And ACOG is now recommending postpartum care that's individualized and person-centered, not that cookie-cutter approach of just a 6-week or an 8-week visit. What else can we do to help support our postpartum patients? As I said before, the WHO says that breastfeeding is a human right. We want to do everything we can to allow that extended skin to skin contact, to be able to say supportive things, right? To tell the birthing person what she is doing well. So often our patients hear what they're doing wrong. And one of my favorite stories is a pediatrician that I had the honor and privilege of working with at Johns Hopkins. And she said, like 20 years later, she had a mom come back to her and tell her that one day when she was talking to her about her baby, and she told her, "You are the best mom for this baby." And she remembered that and has called upon that, and that has helped her to feel valued and to feel like she is a good mom. And this is, decades later. If you're interested more in the protocols around breastfeeding, there's a QR code that I invite you to look at. We also need to involve fathers or birthing partners in the newborn period, right? We know that fathers can help be a great way to connect with the baby through touch and play. Babies tend to need that more vigorous play. So it's just a different role. They can also, those partners and fathers can be super helpful in if they are educated in what is postpartum depression, what are other signs to look for to help be supportive with other mood disorders or other issues or bleeding or other things. They can be a great source of support and information to help keep the dyad comfortable and safe. And also, they can learn about baby's cues and be part of that daily care so that they're part of that family experience. So, what can you do, right? Uh, Words matter, words have power. And so I just invite you to focus on the idea of how do we call our urine drug testing results? So often I hear from my colleagues and patients who are receiving these tests that they'll say, "Oh, I'm clean today," or "Oh, the patient popped a dirty urine," right? Those are incredibly stigmatizing and demoralizing terms in many contexts. And so, especially in the healthcare setting, I invite you to think about using the words that honor and recognize substance use disorders as the medical illnesses that they are. And so using the word positive as well as negative for drugs can be confirming, empowering. And we also know from retrospective data that the words that we use in our charts is related to how patients do and their outcomes. More positive and affirming words, it's related with patients doing better. More negative, demeaning, and stigmatizing terms, it's related to patients with substance use disorders doing worse. I know the chat is disabled, but I'll invite you to think about, and I would love to hear at the end of the presentation, what are some supportive statements that you could say to mother or birthing parent that has an opioid use disorder and who just delivered their baby? Honoring that birthing process, honoring how hard they worked, honoring that they are doing the best job that they can do is so incredibly important. And you never know when your words can be taken for the rest of people's lives. So what else can you do? You can be honest and transparent with your patients. You need to empower them with information. What can they do? What are the limitations of privacy and confidentiality? What's going to happen if Child Protective Services needs to get involved? And what are the resources that they can have so that they know what to do and what the steps are? And before you ask your patients any questions, I invite you to think about, why am I asking this question? What am I going to do with the information when I get the answer? And how am I going to respond? We want to include patients in our decisions. So often treatment of all types is something that's done to the patients, and we forget that the treatment is about them. We need to point out their strengths. There are millions and millions of people living in recovery right now in the United States. We need to point out their strengths, highlight that resilience, use our first language when we can, and knowing our resources, taking a moment to look at websites, to talk to your colleagues about where the resources can be found to help support your patients, telling stories of recovery and success, making sure that we are distributing naloxone to all of our families who so that because it's not just the patient themselves, it's also family members that might also need this help and support. And then advocating for compassionate care diet and hospital dyadic hospital policies. And one final reminder that Narcan can be used for all ages, including babies. With the time that I have left, I want to share with you a very special video by Rose, and I hope we all, I personally aspire to be Rose Horton and how she talks to her patients about care. And I'm going to start.
To really decrease their anxiety and to help ensure that the experience that they have with us at our hospital, our organization, is respectful and it's courteous. I'm sure many of you do this anyway, but here goes. So we're going to do a little role play. Hi, my name is Rose and I'm going to be your nurse today. I know we met unofficially during bedside shift report. Kathy, your night shift nurse, told me that you go by Amanda. Is that correct? Great. Hi, Amanda. I just want to take a few minutes to tell you a little bit about me. And also I want to share with you what I commit to and the time that I'm going to be caring for you. Is that okay? Great. Well, I have been a nurse for 20 years and I've been taking care of women in the birthing community for that long. So I feel very comfortable and very confident in my ability to provide respectful, courteous maternity care. To that end, let me share with you a couple of things that I am committed to. Number one, I'm committed to treating you with dignity and respect. What does that look like? Well, before I enter your room, I'm going to knock on the door first, right? I'm going to knock. I'm going to wait to hear you tell me to come in, and I'm going to come in. I'm going to make sure that I pull the curtains behind me so that I protect your privacy. I will always speak to you in a professional manner with compassion and with kindness. I'm also committed to providing evidence-based care. What does that mean? That means that the care that I provide is based on literature, it's based on data, and it's based on science. We don't make any haphazard decisions here, no opinions. We really provide care in a scientific manner. I'm committed to listening and believing you. Listening with empathy is super important to me. So if you tell me that you're in pain, I believe you. If you tell me that you're afraid, you feel overwhelmed, you feel exhausted, whatever you tell me, I believe you. I also commit to shared decision making. I am here to amplify your voice. This is your birth, your experience. I want to amplify your voice. So what's important to you, it's important to me that it bubbles to the surface, right? That it becomes a priority. And last, but definitely not least, I am committed to being your advocate. You have done an amazing job for 9 months to carry this baby to term. So you know that your body's capable, you're strong, and you are enough. You don't have to worry and be filled with anxiety or stress because you think you're going to have to fight for everything, fight to be listened to be heard, and to have the birth that you want. You don't have to do that. All I want you to do is take a deep breath, relax, allow your body to engage in labor because your body's ready for this. You're ready for it. I got you. I see you. I hear you, and I am your person. So all you need to do is just focus on you, focus on listening to your body, focus on this experience. Together, I'm sure we'll have the birth experience that you have been planning for. That's the end of our role play.
All right. And with that, I'm going to thank you for your time and attention. And I'm happy